board meeting. Great to see so many members of the public joining us. We've had a busy morning as a board, focusing on a whole number of issues. We are looking forward to this afternoon. One of the sessions we had this morning was with Warwick Business School to talk about some of the great research projects we've got going on with them. Just before we get this meeting going now, I just want to mention a few people I know who are dear to a number of us around the table who remain unwell. Charles Ashton, our Chief Medical Officer, has just had an operation. Charles, we hope you recover soon. Fiona is still having treatment, so Fiona Burton, our thoughts are with you. And Charles Hart, who's a dear friend of a number of ours from the Patient Forum, Deputy Chairman of the Patient Forum, has had a big old operation at UHCW. So Charles, if you're watching this in the future, we wish you a speedy recovery. So we have a very full agenda today, ladies and gentlemen. So with your forbearance, I'll try and keep things moving at an appropriate pace. And then members of the public at the end, if you'd like to ask us any questions, that will be your opportunity to do so. Any new declarations? Oh, we have apologies from Paramjit Gill. Any new declarations of interest? Please raise a digital hand if you're a board member. Sarah?
Sorry, it was just I was not quick enough with my hand. It's actually we've also got Sophie's apologies and Jenny's deputising for the public board.
Thank you for reminding me. Thank you, Sarah. So any new declarations of interest, please raise a digital hand. I can't see any digital hands raised, so I will duly note it. The last set of minutes, and that meeting was kindly chaired by Simon Page. The minutes of the meeting held on the 7th of September. If you would like to make any adjustments to that, please raise a digital hand. Okay, I can't see any hands raised for an amend, so we'll go then to the action points arising, which are on page 17 of the pack. The first was regarding the integrated performance dashboard, and Sarah was to provide a reflection on the reasons for the reduction of births at the midwifery-led unit. So Sarah, do you just want to give us an update on this?
Thank you, Chairman. So we've circulated a report which describes the main reasons for the reduction in birth. I think actually if we were to run the reductions through an SPC chart, I'm not sure they would be statistically significant, but we were affected during COVID, and so a lot of it was due to the COVID response. Also, we are experiencing an increase in complexity, which is the national picture. So more births, being triaged to consultant-led care or complex pathways.
That's great, Sarah. And our midwifery team at SWFT does a phenomenal job, and I know David Spraggart and you visited the unit again yesterday. So just want to say thank you again to everyone who's working on the front line of delivering safe babies for everyone. And then on the monthly safe staffing report, Sarah, to ensure the staff unavailability chart or a version of it be reinstated. Are you going to do that, Sarah?
Yes, Chairman, we are working on that. There's just a couple of logistics that we need to sort out in the rotas to make those reports accurate. So where staff are coming through to different lines, it's slightly throwing our KPIs. So we are progressing through the roster reviews at the moment, which hopefully will address some of that. And we have highlighted some of the work in unavailability in the staffing report later on in the meeting. Super.
And then finally on the operational capacity plan and winter plan, Harkamel to have discussions with Basker and Sarah regarding lower level risks in order to obtain further bed capacity, and that's ongoing, so thank you very much. Okay. One of the things I've learned in life is how important it is to make sure you send the right text to different people. I just got a loving text from someone on the board, so I'd like to thank them for their regards, although it wasn't meant for me. So first up on the agenda is a calendar of board and board committee meetings. Sarah?
Thanks, Russell. So submitted to the board for consideration and approval. Each committee has already reviewed their meeting dates, so they should all be accurate as to what they've agreed. So for the board's consideration, please.
Okay, that's great. Thank you very much. So we've all had the opportunity to peruse this. Obviously, it's stretching into 2024, which is quite remarkable in its own way. Any questions? Please raise a digital hand. Can't see any hands raised for questions. So if you're not happy to approve this, would you please raise a digital hand? Okay, no digital hands raised, so duly approved. Thank you very much. So I know a lot of work is on in the background as to organising that document. So can you please thank everyone involved? So we're then on to the Chief Executive's report. Glenn, what would you care to pull out as highlights?
Thank you, Russell. I won't go through all of it because I'm very conscious I've got a big agenda today, but I'll just pull out one or two things. Firstly, we have a new Secretary of State for Health and Social Care, our fourth in 18 months. And last week, she set out her what's referred to as Plan for Patients, which I've included the content of there. A lot of it is a restatement of some existing commitments and some of the things that were contained within the winter plan that we talked about last month. But there are some new things in there. I mean, particularly the focus on primary care, which is a bit of a response to public opinion at the moment, with a promise of appointments within 2 weeks and same-day appointments for those who are urgent. I mean, it's good to see additional phone lines being provided to support this, but obviously, I'm sure our primary care colleagues would like to ensure there's additional GPs to provide this. So I think part of the challenge will be the workforce response to that, but understandable concern from patients that they would like to improve access not only to primary care but also to secondary care, and that's where a lot of the other emphasis within the document is. So the ABCD priorities that the Secretary of State has identified, so ambulances being the first of that. Within this element, it restates the winter plan that we discussed last time predominantly. B for backlogs, and now we have 7 million people roughly waiting on waiting lists for NHS treatment. And just to say what I often say at this point, they're not all waiting for inpatient treatment, many are waiting for outpatient treatment. And we'll look at our own position on that later, but there's a need particularly for us to manage winter demand so that we maintain the improvement that we've seen so far in tackling those waiting times coming out of COVID. The C relates to care, and there is a new announcement here with an additional £500 million for adult social care. We think, although it's not yet confirmed, that will be channeled through the Better Care Fund, which is an NHS allocation given to local authority colleagues. And at the moment, we're not clear whether this is going to be given on a fair shares basis to individual local authorities or based on a perception of need. So we'll be looking at that one carefully. And there's also promises around additional funding within that to boost international recruitment for care workers, which is much needed. And then the D's, although there's another D, is doctors and dentists. Particular emphasis actually on improving access to NHS dentistry, which has again been a major public concern. And some freeing up of some of the rules associated with employment and overseas recruitment associated with that particular pledge. I'll then move on to the strategy refresh. So over the past few weeks, all three trusts in the group have met to review the strategic wheel, which I've included within that. And that wheel has been around, certainly within South Warwickshire Foundation Trust, for a number of years. And was produced before the long-term NHS plan adopted a lot of these things, and was then adopted by the integrated care system, and then by Wye Valley and George Eliot and the integrated care system in Hereford and Worcester. So it's served us well, and we've been testing it out. And we had the SWFT board workshop last week to see whether it's still relevant to us in today's NHS with integrated care systems. And fundamentally it is. But what we talked about in all three boards is the need for us to accelerate some of the progress towards more integrated care and more prevention. So we will be bringing back early next year a revised set of strategic intentions, a lot of which will be common across the group, that will identify those big moves of what we're going to do next in order to realise that vision. I then talk about elective recovery, and later on in our confidential section we'll be looking at a business case that was pulled together in quite short order, that relates to the estates plan that we agreed earlier in the year. This would be a great opportunity for us to get hold of some national funding to put the first element of that plan into place. And we were given a week's notice that our standby bid that we submitted earlier in the year was now likely to be looked at favourably because of slippage in some of the other schemes that were prioritised across the Midlands. So that submission has gone in. We're looking at it confidentially later, and hopefully by the time we get to public meeting next time, we'll be able to talk about where we are with that. I then refer to a visit of Amanda Pritchard, which was great, and she took the time to come out and visit our hospital and community teams. But even greater that she was so impressed with what she saw that she talked about it in a conference I attended a few days later, which was nice to hear. And particularly the frailty model was she was very impressed with. And then we go into some detail of more from our great teams, starting with endoscopy and talking about the work they've done, including the big refurbishment that's gone on over the last year, which has made them, which has addressed the sustainability of their estate for the future. Really positive feedback from students that are part of that department. And then finally, the annual Going the Extra Mile Award winners, which we heralded at our annual general meeting last week. Happy to take any questions on any of that, Chair.
That's great, Glenn. Glenn, can I just ask you, I just want to make a point about intelligent conveyancing myself in just a second, but could you just, for members of the public, brief colleagues on the arrangements that we've put in place regarding Charles Basker and David Mowbray? Yeah,
so Charles is off for at least a 3-month period. Basker, as the recently appointed Deputy Chief Medical Officer, is stepping up to be Operational Chief Medical Officer. And then we have the benefit of David Mowbray as Chief Medical Officer, providing that support to Basker, which is in fact what Charles did for David when he was first appointed a few years ago. So really appreciate David's help and for Basker stepping up into that role.
No, thank you, Basker, and thank you, David. I just wanted to add a point on ambulances and intelligent conveyancing and the implications for us. One of the things we're really proud of is being able to provide mutual aid and support to other providers close by. Because of the relative strong performance of our ED department, one of the consequences of that is quite often we have something called intelligent conveyancing, where ambulances are moved towards us because they know that we perform better than many in terms of ambulance handovers. It does have an unintended consequence, which is when we get patients arriving from out of our geography, it makes it more difficult for us in terms of discharges. So we're still suffering from a significant medically fit for discharge challenge. Part of that challenge is because it is more difficult for us to get people social care packages when they're out of our geography, which is affecting our length of stay on occasion. So I just again wanted members of the public to say that some of our metrics are being affected by the way we are supporting others. Any questions or perspectives to Glenn? Okay, thank you, Glenn. So we'll then move on to the integrated performance dashboard. We're doing things a bit differently from now onwards. So, Anne, you're going to give us a comprehensive briefing. So over to you.
Yes, thank you, Chair. The executive summary that's presented really covers off the key points that my executive colleagues have pulled out. The Chief Nursing Officer has drawn out the continued strong reporting culture, which is very pleasing to see. In the Chief Operating Officer's report and the commentary, it's really helpful to see the benchmarking data to understand our performance against metrics such as ED performance and our ranking there. Also have noticed the improved 2-hour response in out of hospital, the 4th successive month of improvement for our diagnostic weights, placing us placing us 3rd nationally against that metric. Cancer, we continue to experience high referrals, and the team, and I know the team are working exceptionally hard with that focus on capacity and demand that is underway across the tumour sites. And I'm sure Hartmel, as part of our update, to provide that fuller detailed work that's underway on our cancer performance. In the Chief People Officer's report, that provides us the overview of recruitment, sickness, absence and staff turnover, and really taking the opportunity to welcome to the organisation the 46 colleagues who commenced in post with us in August. In the Chief Finance Officer's report, it's outlined and advised that we at month 5 have delivered a break-even position against a £1.25 million surplus. And Kim, going forward, will share with you the detail of the work that's underway in developing our year-end forecast scenarios. So happy to take questions at that point, or to hand over to colleagues. Thank you.
Thank you, Anne. So quick perspective from Glenn or question, then we'll move into the individuals. Glenn?
Yeah, obviously one of the big areas of concern is our increasing spend on agency, both from a quality and a financial perspective. And just a reminder, Chair, that next month we're meeting in public with the 3 boards in parallel, and to look at comparative performance across the group. And we decided that some of the HR indicators are the ones to look at this time. So we will have a useful opportunity to compare and contrast on that.
That's great. Thank you, Glenn. We're all looking forward to that. And staff availability is obviously a big challenge, and we talked about that again at the George Eliot board yesterday, and we'll no doubt touch on it again today. So moving on then to quality and safety. Sarah, what particular points would you care to pull out?
Thank you, Chairman. If I may, I'd just like to add some context to the slides we provided on C. diff infections. So whilst the numbers of C. diff infections across SWFT are very similar to last year, the number of cases that we've had year to date does mean that we are at risk of breaching the annual target that's been given to us by NHSI. So my understanding is that C. diff rates are challenging nationally, and I think that's against a backdrop of NHS organisations running very hot over the summer with limited opportunity to decant and deep clean. But I would just like to offer assurance to the board that we have conducted a multidisciplinary team deep dive of all our C. diff RCAs that we've had so far, and we've developed a really detailed action plan in response. We've also invited IPC experts from NHSI and from our system to both review that action plan and visit our organisation to see whether they are able to offer any additional actions that we may be able to take to reduce the rate of our C. diff infections. So that was all I was going to pull out, because our harm and patient experience metrics are still very strong and very stable, but I'm very happy to take any questions.
That's great. So just before we go to questions, Bhaskar, is anything you'd like to add on quality and safety?
Sure, thanks, Russell. Chair, I think the report refers to the mortality data showing a slight uptrend, and this is something that has been picked up in our mortality deep dive, and we've identified 1 or 2 areas that hopefully will help us learn if there are any remediable lessons there, although some of this may come down to coding issues. So that and the serious incidents are being scrutinized and lessons are always learned and percolated. So I don't think I have anything more to add other than mentioning that mortality reassurance, despite that signal slightly going the wrong way.
Okay, thank you, Pascal, and thank you for sort of putting yourself forward for the role of Deputy Medical Director. It's great when clinicians want to share in the leadership challenges of the board. Any questions to Sarah or to Pascal? Please raise a digital hand. Okay, thank you for those briefings. So Harkamel, the machine is running hot, so to speak. What would you care to brief us on?
Yeah, so I'll take the report as read. The only bits I wanted to pick out were just to say that we reopened Stratford minor injuries on the 16th of August. So we're currently open on Tuesdays and Wednesdays each week. We are hampered by staffing, but we were busy almost as soon as we opened. So within the first day, I think we saw almost 30 patients, which is excellent. The other bit I wanted to just make a point of pulling out was around our non-elective spells. And so we saw almost a historic number of non-elective admissions in August. It was one of our busiest months ever. And I think the only reason I kind of want to pull that out is because when you look at the specialties that are driving that, so specialties like ENT, we wouldn't have seen those levels of admissions relating to that specialty previously. And it goes to tell the story a little bit of the complexity of these patients and the impact of comorbidities. And then, you know, those patients end up being admitted and having a 1 or 2 day length of stay. If we didn't have the SAU, so the surgical assessment unit, the pressure on our beds, I think just would have been unmanageable. So we've absolutely got the right things in place, but it's definitely one to watch with those admission trends. In terms of my deep dive slide this month, I included a bit about the RTT waiting list. We've talked quite a bit about providing mutual aid to other organisations and our phenomenal performance on improving our long waiting list. So as of today, I can very proudly say that we don't have a patient, even with mutual aid, waiting over 2 years. And our plan very much is to try and get down to no patient waiting over 78 weeks. The only patients that we'll see tipping in over 104 weeks will be those patients with mutual aid. So we get them when they've already been waiting over 2 years. But I just wanted to share with colleagues just the profile of our waiting list, and just to show that although the referrals did dip in our waiting list, did shrink during the pandemic, it's absolutely started to grow again. And in terms of the pressure on our services, I think it's just definitely one to watch and just sort of keep our eye on. So the actions firmly remained around focusing on the long waiters. But when I talk about the cancer demand and I talk about the increase in this level of referral, it's the same workforce doing both. So as we move forward, I think it would just be really important to kind of keep those things in mind when we're having discussions around why performance might be dipping or where our pressure points might be. So that's it from me.
Okay, thank you, Harkamel. And you know, with bed occupancy at 97%, it sort of just indicates how busy we are and how full we are at the moment, given that level of demand. Questions and perspectives from colleagues. Glenn?
All of which emphasises how important that theatres replacement project is for us, actually. The thing I was just going to pick up on, since we last met, Harkamel's team featured on the BBC News, looking at the way that they manage the hospital on a daily basis and the way that they manage beds. And I think they came over incredibly professionally in the way that was projected to the public. And also, actually, we've had a visit from the National Discharge Lead, who sent a team in to look at the way that we analyse our medically fit for discharge numbers. And again, that was cited as best practice nationally. So the detail that goes beneath the surface of all of this, of trying to keep flow going in the hospital, is to everyone's credit.
No, thank you, Glenn. Well said. Rosemary?
Harkamel, 2 questions. First of all, COVID, and nationally cases are going up. Are we seeing that in the hospital? And in particular, is that impacting on ITU? And my second question.
Right, can we do one at a time?
Okay.
Yeah, so first question.
Yes, we are absolutely seeing that. So next month I will tell you about how challenging that has been in September. So in my report, we ended August with 16. As of this morning, we have 43 inpatients with COVID. So we're back into those really thorny issues of how we cohort patients. We've also started to see a handful of patients with flu. I did say when I did my winter plan that we expect flu season to start earlier. My personal reflection is this last week has certainly felt like a winter. Some of the pressures that we felt within the organisation absolutely reflect a lot of that. So yes, the numbers are going up.
So I just, again, for members of the public, correct me if I'm wrong, Harkmel, if we're seeing about 25 to 30 people with COVID, we can sort of cope with that without too much difficulty. When it goes above about 30, operationally it becomes more and more of a challenge, doesn't it?
It does, yeah. So if you think about, you know, a ward is about 30-ish beds. So anything over and above that on a footprint our size is really challenging to manage, especially when you have to cohort patients with different things, and we are limited on side rooms. So it's the placement of patients that slows us down.
No, thank you, Harkmel. And Rosemary, your second question?
My second question was just to focus on intelligent conveyancing. And the challenges that the Trust Emergency Department has had faced in the last few weeks, and almost become a victim of our own success. What steps have we got in place to try to manage that?
So you're right. It really does feel like at times we are a victim of our own success. So Glenn shared before that he and I get an hourly update of where the ambulances are at any one time in the West Midlands. So it's not that we're blind to the pressure that the region is facing, and often that, well, every day that is what informs sort of our action. So we can see if that number starts to look hotter in Coventry and Warwickshire, and indeed around the patch, because, you know, if Leicester's busy, then George Eliot will be busy, and then those patients will sort of travel over here. And it's really important that we sort of stay on top of that and respond accordingly. That said, it is really challenging. So we're on the phone to WMAS all of the time to kind of give them a picture of what's going on internally and whether we can cope or whether we can't cope. The problem is, if I said to you, you know, we had really good performance on our 30-minute and 60-minute handover times in August. We've got organisations within the region that have patients on the backs of ambulances for hours. So we are always going to be that organisation that are deferred to in those moments of extremeness, because we just do not see, and we work very hard not to see those sorts of pressures here. One of the things that I'm sort of working on is a way of kind of getting some of that data so that we can be a bit more transparent about some of this, because at the moment it doesn't, in my opinion, it's not always necessarily very clear. And when we're trying to kind of get some feedback on where these patients are coming from, the data doesn't match my experience. And for context, we've currently got 42 patients that are facing exit delays at the moment within the acute. 11 of those are out of area.
That goes back to the point I made earlier, doesn't it, Harkmel? Thank you. Glenn, did you want to come in on that point?
Not necessarily on that point. I just want to come in on the rising COVID numbers issue, and particularly as we go into the winter here. This is just one that we will need to keep a very close eye on. Fortunately, many of those patients are not anywhere near as acutely ill as they were in previous waves. We will have to manage risk this winter. And so the ability to continue to isolate those patients with less risk compared to the risks of ambulance handover at the front door, or patients not actually having an ambulance come to them in the community, will be something that across the NHS we're going to have to look at carefully. I was on a call with some other chief execs last night, and that kind of flexibility of our infection prevention policies will be an important thing to manage total system risk.
No, I think that's an extremely important point, and we will keep members of the public aware of those sort of difficult choices we're having to make in terms of getting the right risk balance. And because the same issue relates to the issue of intelligent conveyancing, the risk of that patient not being picked up is often the greatest risk of all. David Spraggart, then we'll move on.
Yeah, just a comment about Stratford Minor Injuries Unit opening. Great. Is it unmet need that we're actually targeting there, or are we actually going to reduce some of the pressures on Warwick A&E as a consequence? Because clearly it's another avenue for people to access the hospital, isn't it?
So it's early days, and we are auditing on an ongoing basis. At the moment, it doesn't look like we have diverted any activity from the Warwick site, and these are new patients.
I feared that was what you were going to say.
Yeah, but you know, it's really important to kind of carry on evaluating. So just because that's what it feels like now, it's only been, you know, a month or so. So we'll make sure that we're tracking that as we're moving forward. We are doing a patient questionnaire. So obviously we'll know what they came for anyway, but we're asking the patients where they would have gone, you know, if minor injuries wasn't open and any other things. So once we've got enough of that data, we'll be able to then inform what that looks like going forward and try and be as responsive as we can.
Okay, thanks, Harkham. I'll keep us briefed on that, and again, just ensure the members of the community are briefed on the challenges we continue to face. And we'll move on then to workforce and workforce availability. Gertie, what would you care to pull out?
Thank you, Chair. I'll take the report as read. Just a couple of brief points, mindful of time. I think there's been a huge amount of work done in terms of streamlining both our recruitment and our retire and return processes. One of the biggest challenges in terms of staff availability is making sure that those staff, when they have been appointed, are able to join us quite quickly. So there's a lot of work going on around that. So I think that's been really positive and actually really reflects picking up on feedback from our colleagues across the organisation. So I'm hoping that we'll start to see an impact from that. Sickness is still above target, but ultimately going in a downward trajectory, and turnover we can confirm is still at 14.7%. So again, above where we want to be, but we have got some activity going on in terms of flexible working and retire and return. So we're doing that collaboratively with our nursing colleagues at the moment. Other than that, I wouldn't take anything specific out, Chair, and happy to take any questions.
Thank you, Gertie. Questions and perspectives to Gertie. Glenn?
Yeah, just picking up on the slide that shows the vacancy levels, to slide 10 of 27. I mean, what's interesting about this for me is actually our vacancy levels are not dissimilar to they were a few years ago. Although the chart says 18-19, I think it's 19-19. It doesn't quite go back that far. But so the real issue has been increasing levels of sickness absence, I think would be my analysis of that. Is that yours, Gertie?
Yes, so as we've seen our staff and post increase, we've also had corresponding increases in establishment. So it is particularly for us our sickness, and our retirement return figures are actually quite healthy as an organisation. About 60% of our staff year on year tend to return after retirement. So sickness is a key driver at the moment, particularly short-term sickness.
Okay, thank you. And then Phil?
Yeah, Gertie, just on vacancies, can we put it as an absolute number so it's front of mind? Because it might be my eyesight, but with all the different percentages in the graphs, you can pretty well work out what it probably is. But I think because it's such an important driver for us there, it should be total vacancies, front page, front of mind.
Yeah, we'll certainly look at how we do that in terms of triangulating the information between us and the ledger, Phil. Certainly we'll do that.
I think it's worth saying for members of the public benefit, we had a very long discussion on workforce issues as part of our strategy review last week, and the long-term challenges that the NHS and social care will undoubtedly have, given a very low level of growth in the total labour market, to address the vacancy issues and therefore the need to do more and more virtually. So the board are actively considering that type of option. And Simon?
Thank you, Chair. Gertie, I was going to make a similar point to Glenn about sickness, and certainly over the length of the chart, we have a gentle upward trend in terms of sickness, and at nearly 6%, we're over 50% above target. And I just wondered, how do we compare against other best-in-class organisations, and are we confident in comparison to them we're doing enough to try and address this issue?
Yeah, thank you, Simon. I mean, and we will see this next month at the three boards. I think we are broadly similar to other organisations. We've all seen that same increase. from the outset of COVID, and since then in terms of sickness, particularly around short-term sickness. We have got a range of, I think, 70 plus interventions and support options available for our colleagues. There's always more you can do in this area, and we continue to try and action plan and develop what else we can do, and we will receive the health and wellbeing report in our December board, so I think that will give you a greater level of detail. But if you're asking me if we're doing enough, my immediate answer would be no, because my belief will always be there's always more we can do.
Yeah, I mean, it's 6%. I mean, it's a horrifically high number. And finally, Sue, then we'll move on, given how full the agenda is.
Yeah, aware that we might be covering this next month, Gertie, but just to say that flexibility and flexible working seem to be coming through as really key themes with staff at the moment. So it would be good for you to just put your mind to how we best display flexible working and how well we're doing on it for the future reporting.
Good point.
I'll certainly have a look at that. Thank you, Sue.
Not an easy metric to try and think through how we do that. Let's move on to the numbers. Kim. Obviously, things are very challenging financially for the whole of the NHS at the moment, and we're not immune to that. What would you care to pull out of your report?
Thank you, Chair. First of all, just an apology. There's an error with the annual plan figures in one of the tables, but just to confirm that the narrative is correct and the year-to-date figures are also correct, so no issues there, but just felt the need to highlight that issue. We are, as Anne pointed out, reporting a break-even position against a year-to-date surplus plan of £1.25 million as at month 5. In terms of ensuring that we are safe, we've, given the vacancies that we have and the sickness levels, there is a high use of agency, and that comes at a premium cost, which is, driving, the issues with the expenditure position. Lack of CIP delivery due to operational pressures are also contributing to the drivers. However, we do have mitigations in place. We took a finance strategy paper to the confidential board last month, where we talked about some of those mitigations. But just to give an update, we've got temporary workforce groups in place. We've also got PMO support with the governance and accountability for the financial reset recovery programme. We also held a trust-wide CPIP workshop to explore opportunities and resources available really to support the divisions in terms of looking forward. A key focus for me and my executive colleagues is to support the divisions around the delivery of this year's plan, as well as looking forward into the future on recurrent opportunities. And we've got some clear trajectories for delivering the position for this year. We are waiting some national guidance around any potential changes in forecasting, but at the moment the Trust is still forecasting that we will deliver a £3 million surplus for the year end. As Anne's pointed out, I will be bringing back more detailed forecast scenarios to discuss with my board colleagues in the December meeting. I'm happy to take questions.
Thank you, Kim. I think I'm correct in saying that since the last board, it's been confirmed that we are still on the standard operating framework, a level 1 provider, the only level 1 provider in Coventry and Warwickshire. And I think, Glenn, correct me if I'm wrong, the only level 1 acute provider in the Midlands, but I could be wrong on that. Glenn, questions and perspectives?
Happy to confirm that. The thing to add, though, as Kim mentioned, the internal work on cost improvement and cost and productivity improvement. There's a bigger piece of work going on in the background, just so that board colleagues are aware. And we probably need to ensure there's a bit more board visibility of this work, which is called the Warwickshire Transformation Programme, which is looking at how we can redesign services to improve quality, but also by reducing waste in effect in the system, and making ourselves more cost effective. That piece of work has been produced by SWFT Clinical Services, our in-house consultancy. We've chosen to do that. I mean, many other parts of the NHS, sadly, people are still using management consultants for this kind of work. we've led this with our internal consultants. It's a piece of work in collaboration with our George Eliot colleagues, but also our Warwickshire County Council colleagues. And it's shaping together pretty well, actually, with some big opportunities that we can look at for future years' savings. So probably, Kim, that's something we could bring back to the board quite soon so we can share.
Okay, super. Look forward to that, Glenn. And that is an important piece of work, as I know that other systems are often spending millions potentially to get done what we are able to do internally. Okay, team, thank you, Kim, for the update. I think, Bhaskar, we covered off the issue of mortality when I asked you the question earlier, so that was one of the other final charts. So I think we're therefore on to the monthly safe staffing report. Sarah, what would you care to pull out?
Thank you, Chairman. So as Harkmel has already outlined, that the hospital remained exceptionally busy during August, but despite that, this report does offer assurance that we were able to provide overall safe staffing for our patients. So just a few key points I'd like to highlight, if that's okay. Just like to draw attention to the reduction in midwifery vacancies. We're now down to only 4 registered midwife vacancies, and that's against a backdrop of increasing their establishment. So I think that's really good news for the organisation. We've also recently approved a business case which utilises some NHSE funding to recruit some international occupational therapists and diagnostic radiographers. They are the 2 AHP professions that have got the greatest vacancy nationally. So again, that's great news, I think, for the organisation, and that will add to the diversity, I think, of our organisation. We've also seen a further small reduction in pharmacy vacancy rates again, so that it is going in the right direction, although it still does remain challenging. In terms of unavailability, we've already talked about staff sickness, and as this report outlines, that is still challenging and hasn't returned to pre-pandemic levels. I think, if I'm honest, with another wave of COVID beginning, I think that's going to remain challenging for the organisation. But what I would like to highlight is that we've had a really good start to our vaccination, but both flu and COVID vaccination campaigns. So again, you know, preparing our workforce for winter. So they were just the key points that I was going to bring out. I'm very happy to take any questions.
Thank you, Sam. We had a great presentation this morning, didn't we, from the team at McGregor and Vicky and Katie, and all of our wards do phenomenal jobs, but McGregor do a quite outstanding job in terms of looking after children in crisis and young people. So the board thanked that team in particular again this morning. Questions and perspectives to Sarah on the safe staffing report? Okay, Sarah, I think that's all very clear. Thank you. Brilliant news in terms of the midwifery vacancy level. That is quite extraordinary compared to where we were about 18 months ago. So the whole organisation has come behind it. Further investment in midwifery, which is very assuring. With that on, I think, to the Audit Committee report for the 14th of September, including the annual report. Richard, what would you care to pull out?
I'll pull out a couple of things. So I've started as the chair of audit from 1st of September, but certain things Rosemary still handling because they were respect to last year. I think with the external audit, it was a bit delayed this year, but still got an unmodified opinion. One of the issues we had was timing of the year-end audit. So we've got a training session with Deloitte in coming up in November, which will help improve the timing. So that's a good thing. One issue we talked about at the with internal audit is that there's a priority given to bringing forward a review of serious incident arrangements, which has necessitated a slow up in the cyber security work we've been doing. I think the non-execs were all a bit concerned that they're given the problems in geopolitical, slightly to the east of here, we need to be very careful with cybersecurity. There is a lot of work that's being done by external bodies, but we're waiting for the next audit committee to get a report on what satisfaction we can take. Otherwise, we need to prioritise that work. Patient Actions Plan is still ongoing. The final thing is really the annual audit committee annual report for 21-22, which is attached as an appendix. And I think that's all satisfactory, unless you've got any questions for Rosemary.
Okay, great. Thank you, Richard. Love the way at the end you sort of passed on questions to Rosemary. Any questions or perspectives to Richard or Rosemary?
Both of us.
Okay, great. Very clear. Thank you, Richard. So we'll move on then to the Clinical Governance Committee report, including the IPC board update. David?
Yeah. I mean, I'll take the report largely as read, but there's a couple of issues in addition to the ones I flagged, or perhaps I want to reinforce one of the issues that I flagged, was that there are a certain number of potential risks to the trust from factors outside of our control, and some of that relates to others in the system, and I'm just trying to encourage some actions on that. The other was that we had to acknowledge that we had a report from the palliative care team, and it was quite clear that they'd had quite a significant psychological impact from the pandemic. And I think that's something that we perhaps expected, but it is worth noting, really, because they had some very difficult discussions to have. The other one actually relates to the potential for MHRA withdrawing the trust's wholesale dealer license for the pharmacy, which I think perhaps is a bigger risk than people might think, and that's something that I mean, I was asking about the actual impact on the trust, and of course this isn't just this trust, that because of being a wholesale dealer means that you can actually supply medicines to other trusts. So that's something I did want to flag, and I don't know whether there's anything else happened since that meeting that might actually inform me. You're nodding, Glenn. Is that something you do know something about?
I can see Harkamel wants to come in on that one, so we can give an update. Harkamel will give an update.
That's really good. That's really good.
Okay.
Yeah, I've gone away and just had a quick check, and I think we just need to clarify the license that we're talking about. So Samara has confirmed that actually it's about the MHRA license for aseptics, and the impact of that would be significant for George Eliot. It was
misreported then, was it?
Yeah, so there is a license issue, but it's the wholesale dealer's license that we used to be a risk has now been addressed, and we're actually in quite a strong position. So I will rewrite that summary for you if you want, and then we can reflect that in the paper.
That's really helpful, because I was really concerned about the impact that would have if we did lose it. Thank you for that. Well,
if you can do that rewording, Harkamel, that would be great, just for minute purposes. So any other questions or perspectives to David? David, please keep us briefed on those issues outside our control, which potentially can affect our patients.
Yeah, I mean, if you want, the one great example is the fetal medicine pathway, and there are contractual issues that have been lingering for a very long time on that one, which relates to contractual issues with outside of the trust, and that is potentially putting some of our our service at risk. And I think that's something, in my view, is going on too long and should easily be fixed.
Okay, well, I know you're having discussions with non-executive colleagues in other providers to try and help you out. So
I'm doing my best.
So questions, perspectives to David, Rosemary?
Quick question regarding these community staff and travel costs. My understanding was that there had been an adjustment to help them with their travel costs.
Right.
This implies there hasn't been. Is that the case? What is the situation?
It was. I mean, I was only reporting what was discussed at the meeting. I don't know whether there's more detail on that. It's just there's a potential with the fuel costs rising, which perhaps have now plateaued, that for some of the community staff, it was almost uneconomical for them to travel.
Yeah, so we have done an awful lot on this, I'm aware. Glenn, do you want to brief, or Gertie?
Yeah, Gertie got that just behind me. I'm sure Gertie was going to say we have increased on a temporary basis, we've increased the rates of reimbursement for travel expenses for those staff who work in community, and we'll keep monitoring it as we go through the winter.
But there is just for members of the staff, there is a total recognition of the board as to how significant that issue is to some colleagues. So please do shout from the rooftops if you don't feel we're doing enough, and we'll do whatever we possibly can in the constraints that we face.
Yeah, I shan't apologise for raising it, Russell.
Not at all. David, one question from me. I'm conscious of the fact there's been a Royal College report on dermatology at Warwick, and it would be good to understand whether you think it's an issue that any of our patients or members of the public should be concerned about.
Well, I can say, I mean, I've been involved in this for quite some time, and we've indeed discussed it at Clinical Governance Committee in some great detail. I mean, I've seen quite a bit of data that's been looked at this, and I'm fairly confident that, in fact, I'm very confident that no patients have come to harm as a consequence of this, and that we're certainly providing a safe service. There's undoubtedly lessons that we need to learn, and we will act on those. But I think that any of the issues raised are being dealt with effectively.
Great, super. And again, just for public record, I'd like to thank all of our dermatology consultants. I know work very hard to try and deliver the very best service we can to patients with conditions requiring their input. We have a great team of consultants, but we just need to make sure that any lessons learned are appropriately learned. Okie dokie, so we'll move on then to the Foundation Group Strategy Committee report from the 30th of August. Simon, what would you care to pull out here?
Okay, not a great deal, Chair. I mean, there are two reports tabled here for the board. First of all, the meeting of the 30th of August, and then the committee's annual report. And I think they both evidence quite well an increasing level of intra-group cross-working and sharing of best practice, and speak for themselves. So I'm happy to take questions.
Thank you, Simon. Any questions to Simon on the Foundation Group Strategy Subcommittee report? We've obviously got the 3 board meeting next month, which members of the public will be invited to. So somewhat of a challenge to the chair to manage such a big meeting, but hopefully members of the public will find it informative. Okie dokie, so we'll move on then to the board effectiveness annual review. Sarah?
Thanks, Russell. So this report just formalises the process that the board has been through as part of the board effectiveness annual review and captures the areas for improvement. So happy to take the report as read and answer any questions. Thank you.
Thank you, Sarah. So we've all been through this, team. Any questions, please raise a digital hand. I think when we did that piece of work, Sarah, we did get an exceptionally good deal. Some of the numbers I'm hearing quoted at other NHS trusts are 8 times more expensive than we paid for. So well done for the process you ran. We'll move on then to the Capital Programme Quarterly Update report. Jenny, I think you're handing that in Sophie's absence. Thank you.
I am, yes. So just a couple of key points I wanted to pick out. So this is a key report because we are halfway through the year now, and as you can see behind on projected spend, this is mainly due to the risks we highlighted at the start of the year with regard to the volatility of the market, which we're now seeing come to fruition. To mitigate this risk, we are reorganising our capital programme to bring forward items that we can deliver this year. So there are a number of papers in confidential board which relate, including the CT paper, In addition, the elective hub will require some capital spend this year, with DCAT being the focus, and we are still on track to deliver the planned maternity changes, and both of those again will be picked up in confidential board. I just wanted to add as well in terms of the Ellen Badger development, just to clarify the position there. So I'm told we received our BAT licence at the end of last week, and demolition has now begun. So those were just the points I wanted to pick out. I'm happy to take any questions.
Thank you very much, Jenny. Questions and perspectives, Glenn?
I'm glad you picked that out, Jenny, because there's been quite a lot of misreporting of the situation around Ellen Badger. It's been a tricky project, including the latest issue with bats, which obviously once you find bats in a property like that, you do need to respond to the appropriate processes to look after wildlife. So we've put that behind us now, and the project moves forward. The issue still is around the affordability of our GP colleagues joining us on the site, but that's not stopping us from moving forward with the build of the main part of the site, which we're very keen to progress.
No, absolutely, Glenn. Thank you. Any other questions to Jenny? Okay, so we'll move on then to the Council of Governors report for the 8th of September, which Simon kindly chaired in my absence. Simon?
Thank you, Chair. I think, again, the report is self-explanatory and I'm happy to take questions.
Super, thank you very much, Simon. Any questions to Simon on the Council of Governors report for the 8th of September? Okay, thank you, Simon. So we'll move on then to the Digital Health Board Quarterly Report. Adam, welcome. Adam, what would you care to put out for us?
Thank you. I think 3 points I'd like to highlight. So the first is about our patient portal. So we have been continuing our development work, and some really good news over the last month. We're now sharing a significant amount of clinical information via our portal. We've also joined the NHS Wayfinder programme, which links our portal to the NHS app. We went live with the ability to log on to our patient portal via NHS Logon last week, and from next week, our data from our patient portal will be available within the NHS app. We're one of the first acute trusts in the country to do that, so that's great news. Another area of good news is the integrated care record. So this is the single Coventry and Warwickshire shared care record. In the last couple of months, we've gone live with the ability to view the record directly within our system. So that's great news. The first time we've had a holistic care record across health and social care available to our staff. I think the final thing I want to highlight, and it follows on from the discussion earlier at Audit Committee. We have obviously been focusing on cybersecurity. I think it's important to note the issues faced by CWPT in our system over the last couple of months. Advanced, one of the big healthcare system suppliers, has suffered a cyber incident which has taken a number of their systems offline, and CWPT have now been without their EPR for over a month. I think this has highlighted the need for us to focus on cyber security, not that we weren't anyway, and also our business resilience processes. So there's work and discussions going on with both, but it is a significant area of focus and work for us at the moment.
No, thank you, Simon. Adam, rather. Questions and perspectives to Adam. David Mowbray?
Yeah, Adam, with your patient portal, how have you managed the safeguarding and factitious illness risk? In other words, there are some letters that really should not be shared.
Yeah, so the letters we are sharing are quite specific, and we're sharing them in quite specific circumstances. And I'm happy to have an offline conversation with you, David, about how we do that.
Thanks.
I think that would be great, because it would be wonderful if we're able to do it at Y Valley as well as George Eliot. So let's be pathfinders on this type of stuff. Any other questions to Adam? I think generally on the whole issue of the app and digital, again at last week's strategy session, we did talk about the importance of more and more of our services being delivered virtually, but recognising the importance of being understanding and finding solutions for people who find the digital world more confusing or a less comfortable place. So that sort of balance of providing digital solutions to those who love digital solutions and providing the appropriate solutions to those who feel a little bit less comfortable with the digital world, it is an important balance to strike. Okay, Tim, thank you, Adam. So the board assurance framework and risk quarterly report, Anne, over to you.
Thank you very much. So this report is here to provide an update on our board assurance framework, the BAF for 22-23. It's Q2 and the assurance for the red risks on the divisional risk registers. So it's quite a detailed report, specifically around, I suppose, BAF, just to draw out that each of the executives that are responsible have provided their updates against those objectives, and just an overview of the process in terms of the management of red risks on divisional risk registers and our risk management process. And as referenced earlier, there was an update provided to Audit Committee on our progress with the implementation of the recently approved risk management strategy. Happy to take any questions.
Thank you. And any questions on the BAF on this quarterly report? Lots of reds which we're trying to manage down, stating the obvious, but they're hardly high risk issues. Okay, team, so I think we're then on to the items for noting and information. The first is the summary of ratified policies. Anne?
Thank you. 2 policies ratified during September, medicines policy and the diagnostic tests. So just taking that for information. Happy to take any questions. Okay, great. Any questions on the ratified policies? Duly ratified. So then the updated register of directors and register of directors' interests. Sarah.
Thank you. So both have been updated with recent changes, which are shown as bold. So happy to take any comments. Thank you.
Thank you, Sarah. Any questions on the updated registers? Very straightforward, thank you. And then I think we're on just to the board committee minutes, the first of the audit committee of the 15th of June. Richard, anything you particularly like to pull out?
I don't think we need to mention anything because the accounts went to the full board after that date, a bit later because of the delays. So unless anybody's got any questions, take them as read.
Thank you very much, Richard. Any questions on those audit committee minutes? All very straightforward, thank you. And then the Clinical Governance Committee of the 10th of August, David?
No, I've nothing to add. I haven't already mentioned it earlier.
Okay, thank you, David. Any questions on those minutes? Please raise a digital hand. Okay, team, we're on to any other business. Any other business, please raise a digital hand. Okay, no any other business. Questions from governors and members of the public. Sarah, I think we did have one, but we may have covered it off earlier. But just out of completeness, could, in his absence, you read out Roger's question?
Thank you. So Roger Lloyd, the Public Governor for West Stratford and Borders, noted that the Audit Committee received a report on single tender waivers, but there's no comment on whether there is an increase or decrease in waivers, either in value or number from last year. So he asked if the Chief Finance Officer could confirm that the waivers decreased in both number and value. Thank you.
Kim, are you able to answer that?
Yeah, I can confirm. So for the same period for last year, we had 19 waivers of a value of £764,000, and that's been reduced now to 16 waivers with a value of £622,000. So there is a reduction in both numbers and value.
Thank you, Kim. Very clear. Thank you. And any other questions from members of the public, if they'd like to raise a digital hand? Okay, I can't see any digital hands raised. Just a general point though, before I pull the meeting to a close, the board is still of the view that we are entering the most difficult winter period we have ever seen. With the level of bed occupancy we have, with the understandable fatigue and workforce challenges that we face, it is even more important for members of the public to help the Trust in terms of self-care, community care, looking after your neighbours, but importantly in the subject of COVID and the flu, please, when you're offered a COVID or flu injection, please go out and have your vaccination. Every step is being taken to try and make the process as easy as possible. And I think all the board now have had theirs done. So I would strongly encourage members of the public to do so. But in the meantime, take care and look forward to seeing you at the 3 board meetings at the beginning of November. For board colleagues, I suggest we have a 10-minute comfort break. We get back together again at 3:15 for the long confidential board that we have. Thank you.